All right, everyone, and welcome to part 2 of our endocrine lecture. So in the part 1, we went on ahead and we focused on our thyroid disorders. This one's going to focus more on the adrenal disorders. We're going to lecture a little bit longer on this one, but there's a lot of good content. They are not necessarily unimportant adrenal disorders. They're just less commonly seen than the thyroid disorders. Again, between the hypo and the hyperthyroid states, you're talking roughly 27 million affected people. That is definitely not the case when we talk about adrenal disorders. Fewer people are affected, but it's still incredibly important to know what both states are for increased or decreased functionality of the adrenal glands, as we have more than just one or two hormones we're talking about here. So let's go ahead and get started. So you're going to see right off the bat, we've already kind of looked at where these different glands in the body are. We're going to expand on that a little bit more now. We're taking a step down from the thyroid to the adrenal glands, and they are located in the retroperitoneal cavity on the superior aspects of your left and right kidneys. Okay. Fun fact, your kidneys do sit, one sits just a little bit higher than the other. That is consistent with in everybody. Okay, but your adrenal glands are actually really important and responsible for the production and release of cortisol, also known as glucocorticoid, because it is a sugar-based steroid hormone. Aldosterone, incredibly important to regulation of blood pressure, fluid retention, and sodium retention, also known as a mineralocorticoid. We have our androgens, our sex hormones is what we're referring to whenever I say androgens. Think estrogen, think testosterone. And then we have the adrenal medulla, and that's responsible for the release of epinephrine and norepinephrine. Once again, fight or flight, SNS versus PNS, increase of activation versus decrease or downregulation of activation. So let's continue. You definitely need to know the adrenal cortex HPA axis. So the hypothalamus pituitary adrenal axis. We talked about hypothalamus pituitary thyroid. Now we're doing hypothalamus pituitary adrenal. So your body perceives stress, perceives an outside influence on the body, and a perfect example is really the fight or flight symptom, or system. Hypothalamus goes, oh, hey guys, I'm going to go ahead and release CRH. Once again, green light, red light with the pituitary gland. The anterior pituitary gland releases ACTH, okay? And then the adrenal gland goes, cool, I'll go ahead, I'll release cortisol, we'll increase our blood glucose, amino acids, and fatty acids. In the short term, perfect. Okay. Also, not just the adrenal cortex, but the adrenal medulla also perceives the stress and activation of the anterior pituitary and goes ahead and releases epinephrine and norepinephrine. So, what do we get? What we get is increased gluconeogenesis, meaning a dump of blood sugar, okay, or increase of blood sugar as a result of the cortisol activation and release into the system. We are actually decreasing the uptake of decreasing the uptake, of sugar, and we are increasing the blood sugar available to the cells to increase metabolic production of, ATP. My apologies. We enhance centralization of fat deposits. Okay, so when you keep cortisol levels, a perfect example would be nursing school. Nursing school is stressful. Your cortisol levels are increased during this period of time. I had mine drawn, ironically, I believe in like 5th or 6th semester, and mine were elevated. I don't remember how high they were, but they were definitely elevated. And and a lot of you guys right now are sitting here listening to this lecture, and you're like, yeah, I've gained a good 10, 20, maybe even 30 pounds since the start of nursing school. Cortisol is a wonderful thing. So, knowing what that is, converts proteins into carbohydrates, resulting in tissue wasting. We depress immune responses, promote stress resistance through anti-inflammatory actions, and we have fluid and electrolyte imbalances that can occur in the long run, the longer we retain cortisol levels in an elevated manner. So, mineralocorticoids, aldosterone, increase sodium reabsorption in the distal loop in the kidney, and as a side effect, not a direct effect, but as a side effect of retaining more sodium, we're also going to reabsorb more water, and we're going to pull more of that back into the vasculature and keep that in the bloodstream, increasing blood pressure and increasing fluid volume available for the heart. So it's a bad thing. It's a bad thing in the long run, and typically this is one of those things that when cortisol and diet and lack of exercise are all put together, you end up in a state of typically hypertension or pre-hypertension. So if some of you took your blood pressure prior to nursing school and knew exactly what it was on a regular basis, I bet you money, if you've been very stressed, it's probably a little bit higher now, even by just maybe 10 to 20 points. So, fun facts. We're going to talk about different adrenal cortex issues: Cushing syndrome, Cushing's disease, Addison's disease, and adrenal insufficiency or acute crisis. Let's start with Cushing syndrome. Okay. Oh, you know what? I just realized what I did here. I sincerely apologize. CRH, and I said it out loud in my head. I didn't say it out loud for you. This is corticotropin releasing hormone. Okay, and that is the red light, green light. So just how the hypothalamus sends out thyroid stimulating hormone, the thyroid activating hormone to the pituitary, we're sending out corticotropin releasing hormone to the pituitary, and then sending out ACTH from there, adrenocorticotropin hormone. So just my apologies, I forgot to put the actual names in there. Cushing syndrome. So what do we have? We have excess adrenal cortisol production. We have too much cortisol. Exogenous, and really quick, you're going to hear two terms here, endogenous and exogenous. Endogenous refers to hormones or steroid bases, which our body produces all on its own and releases without any outside influence. Okay. When I say exogenous, we're talking about any steroids or hormones influenced and administered from outside the body. A perfect example of exogenous steroid use, specifically glucocorticoid use, would be Solumedrol, for example. Okay, it's a great tool for anti-inflammatory functionality in the acute care setting, but we typically don't want to stay on glucocorticoids for prolonged periods of time or long-term use. Okay, adrenal. So just like the thyroid has its causes, we have our causes here. Most common causes are neoplasms. Okay, autoimmune disorders, which would be Cushing's disease. But Cushing's syndrome just says, hey, I have too much cortisol. Why? Could be a variety of reasons. We have ectopic ACTH production, meaning a neoplasm of the lung, pancreas, kidney, thyroid, or thymus, meaning an ectopic ACTH production is a mirror of the pituitary gland, the anterior pituitary. The anterior pituitary is responsible for releasing ACTH solely. However, there are neoplasms that can occur in these different locations of the body that mimic the anterior pituitary, and unregulated by the hypothalamus just continually dump ACTH into the bloodstream, activating release of cortisol. In this case, this requires you to go to a specialized physician to identify that you have a neoplasm somewhere in the body. We typically identify it with scans. Okay, we find concentrations, and we even draw ACTH levels. And once we draw the ACTH levels and detect an elevation, you're typically going to get an MRI of the brain, and then we're going to go ahead and do a CT of the chest and the abdomen. Okay, and typically we do it with contrast. When we do this, we can actually find concentrations of tissue, neoplastic tissues or cells that are brand new. They don't belong there. We know that. We test them. We go biopsy them. Boom, and we find out what they are. Again, those are external, ectopic, has nothing to do with the anterior pituitary, nothing to do with the hypothalamus, just cellular growths that are doing something they really shouldn't be doing, resulting in increased cortisol production. Okay, we can also have direct growths or neoplasms on the adrenal glands themselves, resulting in excess cortisol. Just like with the thyroid, you could have a growth resulting in increased T3, T4. So, Cushing's syndrome is a little bit different than Cushing's disease. Okay, Cushing's disease is typically caused by influence of the anterior pituitary gland, resulting in ACTH excess production and resulting in increased cortisol production as a side effect. Okay, so what are some of the symptoms that we can see with patients with increased cortisol levels due to exogenous use of steroids? We have, or why, I guess I should say why we're using exogenous. We use them for a lot of things. One of the most common ones, a lot of people forget this, your inhalers for asthma patients, and not the albuterol, not the rescue inhaler, but the maintenance inhalers, almost all of those are exogenous glucocorticoids, inhaled glucocorticoids to keep inflammation down in the lungs. Prolonged use of exogenous glucocorticoids or steroids of any kind for that matter are not good. And I'll explain why here shortly. But the most common causes of why someone would be using exogenous steroids: autoimmune disorders, systemic lupus, for example, connective tissue damage, inflammatory disorders, RA, rheumatoid arthritis, or IBS or IBD, okay, whichever one you want to use there, asthma, COPD, adrenal insufficiency or crisis, chemotherapy often results in widespread inflammation throughout the body, and we see it there. And post-transplant as an anti-rejection means to suppress, I'm going to point it out one more time, suppress inflammatory properties, increase cortisol suppress the immune system. Anytime cortisol levels are elevated, the immune system is absolutely suppressed. Okay, keep that in the back of your head. It's not just that I have increased sugar, I have increased fat stores. It's not just that. Okay, I'm also suppressing the immune system. Don't forget that piece, please. Actions of cortisol, just kind of covered a little bit of it. Causes atrophy of lymphoid tissue, suppress cell-mediated immune response, decrease antibody production, immunosuppression. Put a star next to that one. Altered carbohydrate, protein, and fat metabolism. Remember, we can actually turn proteins into carbohydrates, into sugars, to stimulate hepatic glycogenolysis. Okay, and also as a result, because of that elevated blood sugar or glucose, we can end up in a state of insulin resistance over periods of time. Protein breakdown for glyconeogenesis leads to skeletal muscle wasting. Yes. And then we mobilize free fatty acids and redistribute fat. Sound familiar? So if you came to nursing school, your cortisol levels have increased. Maybe they haven't. Maybe you're cool like a cucumber and you're having no problems. You're over here either getting a fantastic A without even trying because you just have that memory. See it one time, remember forever. Or maybe you're like me. B's and C's get degrees. No, I'm just kidding. Don't do that. Try your hardest. But in all seriousness, you may have looked at your body, and the increase of cortisol since the start of nursing school has resulted in weight gain, increased blood sugar levels, decreased immune system functionality. Maybe you've been sick more often, and maybe, just maybe, you have some new fat deposits in places you might not have had prior, or maybe you had limited fat deposits prior. These are all actions firsthand of cortisol on the body. Okay, and then on the back end, we've already talked about it. We're pulling in more sodium. We're pulling in more water. We are losing more potassium in that distal loop where we typically be reabsorbing it more. It also affects your magnesium level in a very passive manner, but typically we don't see hypomagnesemia due to the cortisol elevation. That's a very latent side effect. You're talking, I've been in cortisol elevation for decades at that point. But this is more to do with aldosterone than it is to do with cortisol. Anyhow, just keep it in the back of your head. We're messing with electrolytes and fluid balances. So, what are some effects of corticosteroid therapy? Anti-inflammatory, great. Immunosuppression, not as great. In most cases, in some, it's very great. When we get a new organ, not our organ, donor organ, body looks at it, I'm going to attack it. No, we don't want that. So we give corticosteroids, typically intravenously, and then PO afterward, or by mouth afterward, to suppress the immune response and stop your body from just absolutely annihilating this brand new organ you just got. Okay? Sodium and water retention. Diabetes mellitus can be steroid induced. You should put a star next to that one. You'll hear these people that have maybe existed in a state where they were borderline but didn't have any presentations consistent with type 2 diabetes. Okay, and all of a sudden they've been on steroids or they had to start taking steroids for a long period of time, typically 3 months or greater. And it's not uncommon to see. Sometimes they start with presentations of pre or early type 2 diabetes symptoms, and all of a sudden, before you know it, boom, they're type 2 diabetics. We have hypertension, atherosclerosis. We have GI ulcerations. This is why you see PPIs, proton pump inhibitors, come into play. You'll see the Protonix or the Pepcid are the two most common. In fact, one of the most common things, and here's one you may also have had, when you see people that are taking steroids over a prolonged period of time, or you have increased cortisol levels over a long period of time, you end up with GERD. And it's we don't talk about it very often, but it is a latent side effect, actually, due to decreased functionality of the GI tract and suppression of the microvilli's ability to move food along. You're actually decreasing your absorption and digestion rate, resulting in gastroesophageal reflux on occasion. So, I'm not talking about, I ate some food and this specific food gives me GERD. No, I'm talking about, like, I'm very stressed lately. I drank milk and I got some esophageal reflux. No, that's an extreme case. Common with corticosteroid use over prolonged periods and cortisol elevation over prolonged periods. Osteoporosis, cataracts, and we can have psychological effects too. Depression is very common. So, fun fact. Cushing signs and symptoms, what do we have? Rapid weight gain. Typically in the trunk. We don't usually get arms. So you'll see somebody with a very large trunk. The diameter is increasing rapidly. Waist is increasing rapidly. But the arms and legs don't seem to be having a lot of fat deposits. Okay. Moon face, acne. I love this next word. Telangiectasia. Okay. That's enough of that. Telangiectasia. Anyway, this is good as it's getting. Thing of the skin, hair, easy bruising, purple-red striae, especially on the abdomen. Also known as, they kind of look like stretch marks that won't heal. They're like fresh stretch marks that won't heal. That's how they look up here. I'll show them to you in just a second. Hirsutism in women, so that excess face. Gynecomastia excess hair on face or body tissues where otherwise they would not have excess hair or thicker, coarse hair. Gynecomastia on males, so the enlargement in breast tissue. And testicular atrophy, and then also that fat deposit on the back of the neck near the cervical vertebrae, resulting in what appears to be a buffalo hump. So I apologize, I stumbled through my words there, but you can see that moon face there, that circular. Okay, we see the flush tissues, pink tissues. All right, see that? The striae. Yeah, those are stretch marks. Yes, they are. But they're also very, very vasculature stretch marks. Typically, stretch marks begin to try to heal. These will not. You can even see if you look closely. Look at the vasculature through these stretch marks. It's very different than just a normal stretch mark. Okay, and then we see that buffalo hump. We see that fat deposit near the cervical vertebrae. Okay, and the telangiectasia or castasia is just the reddening of the cheeks due to capillary beds in the surface tissues, either breaking or rupturing, or having excess blood flow to the cheeks and superficial tissues. Cushing's diagnostics, full physical and exam. Cushingoid features, these are Cushingoid features. Plasma cortisol and 24-hour urine for free cortisol, absolutely. We're going to do a dexamethasone suppression test, CT MRI of the adrenal glands to identify any growths or adenomas. MRI of the pituitary, same thing, growths or adenomas. CPC, CMP, and glucose, because we're also going to look for any neoplastic conditions with that CBC. And by the way, it doesn't say it here, but we're going to be doing a CBC with differential. I need to look at my eosinophils and bands specifically if we're suspecting neoplastic conditions. So keep these in mind. These are the tests we're going to conduct. If I ever ask you, how do I diagnose? What test would I use to diagnose Cushing's disease? I expect you to be able to give me these tests right here. Thank you. Cushing's treatment. How do we treat it? Well, if the cause is exogenous and I'm giving steroids, and that's my crux, I'm going to stop the steroid therapy. Thing is, you cannot just withdraw full steroid therapy. You will send a patient into absolute pure rage. What you do is you wean them slowly and ease off of it if you are on a high to moderate dose. If you're on low dose steroids, no worries. We can go ahead and just discontinue those and just watch the patient closely. But if you're on high dose steroids and you've been taking them for quite some time, you got to come on down off them slowly. Your body will go through withdrawals, physiological change withdrawals. So adrenal steroids, inhibiting drugs. Let's see what else. Stop if able. Adrenal neoplasms. If you have an adrenal neoplasm, okay, so that growth on the adrenal gland, you may have, if you can't just take the growth off and it's not superficial, what's going to end up happening is you're going to have to go ahead and remove the entire adrenal gland, okay? Pituitary adenoma, same thing. If we can do a transsphenoidal resection or a hypophycectomy, excuse me, I haven't heard that one in a while, hypophycectomy. I have heard transsphenoidal resection. We can do radiation therapy to shrink the adenoma, or we can go ahead and remove part of the if it's superficial to the pituitary gland and we can remove it, we will, but it's incredibly challenging surgery. They actually go through the brain pan, the bottom of the brain, bottom of the skull, and access it via that route, because there really is no good or other way to the pituitary gland. It's quite the messy endeavor. High-risk surgery. This one, not as much. We can take off an adrenal gland, no big deal. It's as simple as blocking off the blood flow pathways and then going ahead and lysing and removing. So what are we going to do with Cushing's? We're going to monitor vital signs, daily weight, dietary intake, labs, and especially glucose and A1C. We're going to assess for increased levels of ACTH. We're going to look for cardiovascular symptoms, steroid-induced diabetes. We're going to look for hypertension. So really quick, I didn't touch on that right there. We're going to actually look for hypertension and cardiovascular stressors. We're going to look for pitting edema, +1, +2, in the periphery that could indicate right or left-sided heart failure. We're going to go ahead and look for GI ulceration, potentially start this patient on a PPI. We're going to look for infections, sepsis, fractures, myopathies due to decreased osteogenesis or osteoclast activity increase. So we're breaking down bones. We aren't replacing the breakdown. We're going to look at acute adrenal crisis with DC of steroids. And you could essentially say steroid words. Steroid storm, essentially, is what it would be. Withdrawal storm, and I'll talk about that in a moment. And then emotional upset and changes related to the actual physiological appearance that increased. I mean, come on, if we're being absolutely honest with one another, when we look at our bodies and we see that increased fat deposit and we're looking at that increased everything, it does have an impact on your overall psychological state. And I think we, in general, look at ourselves from the outside in a mirror and feel a little bit better. We are more attractive. We haven't had increase in weight and so on. So, adrenal insufficiency. This would be the opposite of the adrenal cortex overfunction. So that's Cushing's. Overfunctionality of the adrenal cortex is Cushing. Hypofunction is going to be Addison's related, or a termed Addison's. Our primary cause, Addison's disease, autoimmune disorder. Just like the thyroid, we have an opposing we have an opposing disease of Cushing's, and that's going to be Addison's. Autoimmune disorder, we aren't producing enough cortisol. Causes, well, either pituitary is not secreting enough ACTH, or I have some kind of issue like adrenal atrophy related to exogenous steroid use. There's this thing that your endocrine system does, and it's actually pretty intelligent, and your body regulates quite well. What happens is, if your body has an organ that is responsible for regulation and secretion of a hormone directly, and it senses that it doesn't need to secrete that hormone any longer, the gland itself, whether it's your pancreas or in this instance adrenal gland, will decrease production of its hormones. In doing so, if the cells lie dormant or inactive for prolonged periods of time, the tissue actually begins to die and shrivel up and dissipate. And when that happens, it can actually result in permanent loss of the adrenal functionality. So if you're on long-term exogenous steroid use with glucocorticoids, it's not one of the side effects could be adrenal atrophy resulting when I cessate from these drugs. If I ever cessate from these steroids, I can no longer produce cortisol on my own. So, adrenal insufficiency, adrenocortical insufficiency, clinical condition, occurs in 90% of the adrenal cortex. It's destroyed or non-functional, okay, or just we're not getting ACTH activation of any kind. Most common causes, hands down, autoimmune disorders, and we already talked about it. It's going to be Addison's. Okay, granulomas, tuberculosis, sarcoidosis, chronic infections, HIV, AIDS. Genetic defects is rare, but congenital adrenal hyperplasia, okay, surgical removal, post-adrenalectomy, and adrenal artery emboli, probably the most uncommon, but thinking pulmonary embolism, but in the adrenal gland. There's a clot, blocking off blood flow kills it, adrenal gland dies, no longer functional. Secondary, abruptly stopping synthetic glucocorticoid hormone therapy. I already talked about it. Surgical removal of the pituitary gland itself or removal of the adrenal glands. Pituitary, that's the actual removal of the adrenal glands would be primary. I apologize. Secondary would be adrenal or pituitary gland removal. Pituitary gland decrease in size or stops producing ACTH because of tumors, infections, loss of blood flow to the pituitary, clot. Radiation for pituitary tumors, okay, or surgical removal part of the hypothalamus. As you can see, it's a cascade system. It's trickled down. Hypothalamus responsible for the pituitary responsible for everything. And if you're not getting my analogies, the hypothalamus is the coach. The pituitary gland is the quarterback. Okay, the quarterback calls out to the different glands throughout the body and tells them what plays they're going to be running and what they're going to be doing. Okay, if your quarterback goes out and stops functioning, those glands that rely on the pituitary will also stop functioning, or they'll have impaired functionality at least. Okay, if the hypothalamus goes out, you can assume that everything downstream of the hypothalamus is also going to have dysregulation or complete impaired functionality as well. So, somebody that had Addison's, maybe you know this, maybe you don't, is JFK. And the way you could tell in this fantastic black and white picture is his skin pigmentation. ... I really have zero understanding. By the way, we do have, just so we're all on the same page here, maybe some of you guys are young, that's okay. We do have in color pictures of JFK. I'm not quite sure why the producer of this particular slide decided to go ahead and pick a black and white picture of JFK to show you how hyperpigmented he was. And by hyperpigmented, I mean he had increased levels of melanin in his skin, making him appear tan at all times. Kind of like a spray-on tan, if you will. Okay, it wasn't because he sprayed on tans. Sprayed on tans weren't a thing back in the 50s. No. What he had was Addison's disease. Also, whoever made this slide, I'm starting to question whether or not they have brain cells. It was me. Clinical manifestation of adrenal insufficiency, progressive weakness, fatigue, weight loss, hypotension, GI distress, specifically nausea, vomiting, hyperkalemia, hyponatremia. Okay, you're going to end up with salt cravings for sure. Hyperpigmentation due to excess ACTH effect on melanocytes. Severe insufficiency results in Addisonian crisis, also known as acute adrenal crisis. We'll talk about that in just a second. How do we diagnose it? Real simple. ACTH stimulation test. What we should see, okay, if we give ACTH or stimulate ACTH levels of the body, would be a rise in serum cortisol. If rise in serum cortisol does not occur, ACTH would be questioned, and the ability of the body to regulate ACTH would also be further in question. We would do diagnostics of the pituitary gland, or we would do diagnostics of the adrenal gland itself. CRH stimulation. Okay, so we're going to go ahead and look at our levels again. If I have high levels of ACTH, but I have no cortisol, we're going to lean into Addison's disease as the primary cause. If I have an absent or delayed ACTH response, we're going to be looking at the pituitary gland, and that's going to be considered a secondary causation. Okay. So this one. Now let's step into the realm of life-threatening. We're talking about acute adrenal crisis, also known as Addisonian crisis. When we're talking about this, we're talking about severe hypotension. Okay. Again, no cortisol, no aldosterone. I can't retain fluid. I can't retain sodium. Severe hyponatremia. Okay, and I'm going to touch on that really quick on its own. Excuse me. Hyponatremia is either caused by one of two things. I either have hyponatremia due to increased fluid volume in my bloodstream, which is giving us false accuracies or false readings on our chem panels, and it's essentially diluting my entire bloodstream, resulting in decreased blood levels. So before we ever look at fixing hyperkalemia, hyponatremia, I first need to get your fluid levels right. If you have a patient in adrenal crisis, I can guarantee you're going to get a CDP. And the doc's going to look at that CDP and ask, are they overhydrated or underhydrated? And in the case of somebody in acute adrenal crisis, they're almost always underhydrated. They are not retaining fluid. They are not retaining sodium. I'm going to point out that would mean they're hyperconcentrated. Okay, if you're hyperconcentrated and you're still severely hyponatremic, we have to correct that by giving you sodium back. The thing about it is, and as a general rule of thumb, you cannot hypercorrect. You cannot quickly correct hyponatremia. If you do, you will kill the patient's neuron capacity. You essentially demyelinate the neurons, and you actually can lose sensation, motor function. It's predominantly in the peripheral nervous system. So what we don't do is we don't ever correct hyponatremia, period, on its own, quickly, and especially in acute adrenal crisis where our bloodstream is our blood is hyperconcentrated, and these levels. So when you get your first sodium reading in an adrenal crisis patient, it's going to be 120, 119, 118. Oh, that's low. Let's start correcting. No, it's not low. It's super low. Because the minute you get their hydration back where it should be, you're going to start pulling sodium levels closer to 111, 107, 105. So we have to very, 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 very slowly correct that level. This patient will go to the ICU. They will be intubated, and I will manage them from all aspects. And I mean all aspects. Hypoglycemia, we're going to take care of that. Maybe some AMSA D50. Hyperkalemia, okay. As we start balancing things back out, that'll come down. We'll start pulling potassium back in or supplementing, okay. We got to get to and here's the other part with any condition, any adrenal gland, any thyroid gland, you have to get to the bottom of the condition, okay, if you are in a life-threatening emergency. It's no different for Addisonian crisis. It's no different for thyrotoxicosis. It's no different for mixed edema comas. You got to get down to the bottom of the cause. Okay. Otherwise, it'll come right back. Fever, GI symptoms, nausea, vomiting, diarrhea, profound weakness, confusion, altered level of consciousness. Look at the medication history. Ask yourself if they have been on exogenous steroids. This condition typically doesn't just suddenly happen. And being at the most common cause of this is autoimmune. Secondary is medication induced. You need to be aware of their medication history. You got to get that med rec. What do we do to treat it? It's actually really easy. Give cortisol. Not give cortisol, I should say. Elevate cortisol is what I should say. How do we elevate cortisol? Hydrocortisone, prednisone, dexamethasone, Solu-Cortef or Solu-Medrol, aldosterone, fluticasone is acetate, also known as Florinef, okay, and increase the salt intake. By the way, many of you may not know this, and I love how many of you look surprised when I say it out loud. Maybe you've seen it already. Maybe you're already aware of it. Another name for aldosterone in IV form is vasopressin. Vasopressin is a vasoconstrictor, a good one at that. And it's why vasopressin is so effective at helping many patients that are in shock, because it helps you retain volume and helps you retain sodium. It does have vascular properties that activate receptors, specifically 1, 2, and 4 receptors in the vasculature responsible for angiotensin enzyme excitation, resulting in vasoconstrictive properties in the peripheral vasculature. So we're going to educate the patient on what they had, what caused this. We're going to find the cause. If it's cause is simple, cool. Fix it. Move on. In the meantime, while we're looking for that cause, we're going to go ahead and start giving you steroids, exogenous steroids. Okay? Even if the cause was not that you were taking them and now you're not, this will still help you. Exogenous steroids is the first line. What are we going to give after that? Well, we need to do a couple different things. We've already got steroids down. I'm going to give you fluids, and I'm going to give you sugar. Well, what better way to do it than do both at the same time? I'm not giving you D10NS. I'm giving you D5NS. We are going to correct things, and we're going to correct things slowly. Okay? As a general rule of thumb, it's typically, and again, it depends on what book you read, but 0.35 to 0.4 mLs per kilogram per hour. So if you weigh 200 milligrams, or actually here, let's do an easier one. Let's milligrams. Weigh 200 milligrams. If you weigh 100 kilograms, and I say we're going to do 0.4, that would be 40 mLs an hour. Okay. On the higher end, you could potentially see 0.5 mLs per kilogram per hour, but typically it falls in the range of 0.35 to 0.4. Okay, sometimes you do see 0.5 in certain circumstances. Sodium replacement is happening in the form of NS. We're going to treat the hyperkalemia. By the way, ironically, the way you treat hyperkalemia is to give Kxalate. We're going to go ahead and give them, basically I want you to have bowel movements, and Kxalate pulls it into the bowel and allows you to defecate it out. We're going to give insulin and calcium gluconate, but I can't do that until we have your sugar levels back up where they need to be. Now, sugar levels, I don't need to worry about correcting sugar levels slowly. It is not like sodium. I can go ahead, if you come in with a sugar of 10, 20, 30, 40, you're going to get hit with an AMP at D50 pretty much right away, and reassessment of that blood sugar Q 30 minutes, Q 1 hour. Okay. After we get you stabilized, and we've stabilized your blood sugar, we can go ahead and monitor, PRN. Typically Q4 in just general instances. In a more acute cases, Q2 at least. In instances where you're having to use insulin to manage the severity of the hyperkalemia, Q1. Energy conservation, profound weakness, close monitoring, level of consciousness, hemodynamics, respiratory status, urine output in labs. We're looking at all that. But this is just right here. This really isn't anything special. This is a common day in the ICU. This is just normal stuff we monitor. We already look at all this anyway. Pheochromocytoma. So let's talk. I don't know a ton about it. I do know what it is. It's a rare condition, any age. Tumors on the adrenal medulla. The adrenal medulla oblongata is not a thing, by the way. Usually benign, but what it does is it releases excess catecholamines, specifically acetylcholine. Clinical manifestations, severe hypertension. Absolutely wild hypertension. Okay, so what's happening here, by the way, if you haven't figured it out yet, we have just beyond excess production of epi and norepi. You are in a constant state of activation and excitation. Like the sympathetic nervous system is active, cranked up to 1,000. Okay, that's what's happening. Pounding, throbbing headache because of the vascular constriction in the brain occurring, tachycardia, sweating, anxiety, fluttering in the chest, difficulty breathing, It can last minutes to hours. It depends on what the cause is. If the cause is a tumor, typically there's a gradual onset into a severe onset, and by the time we get to that severe onset, we need to treat very quickly. Okay. Hypertension episode can be provoked by many things. MAOIs, monoamine oxidase inhibitors, amphetamines, cocaine, any kind of activator essentially can cause something like pheochromocytoma, where you have that growth, that tumor on the adrenal medulla, to excite further release of hormones and cause this state. What do? Well, first we got to diagnose it. Okay, you're going to come in. Check this out. This is fun. You're going to come in. I'm going to see it. I'm going to give you 10 of them. And this is how it usually goes. I'm going to hit you with 10 milligrams of, if you're coming with a blood pressure of 280. Yeah, I'm going to come in. You're going to come in. I'm going to go ahead and immediately get you upgraded to ICU status. We're going to immediately hit you, before I even start the nitro drip, with a 10 push of metoprolol, and it's not going to do anything. And by the way, 10 of metoprolol is actually quite a bit. Okay, it won't do a darn thing. Okay, because the etiology behind your causation here, or the etiology of pheochromocytoma, is that you're essentially dumping vasopressors and vasoactivators, ionotropic, chronotropic, dromotropic agents into the bloodstream uncontrolled nonstop. So what we have to do then is do a 24-hour urine measure for catecholamine metabolites, CT scan, MRI of the adrenals. Okay, find that tumor. We got to get rid of it. Got to get rid of that. And the thing is, I got to get you stabilized first. So what you're going to end up, you're going to either be on a cardizem and a nitro drip or some combination thereof, depending on your presentation, depending on severity, depending on what works. But typically the cardizem is going to come first, potentially nitro secondary or tertiary, depending on how we're doing things. I've seen different approaches. The cardizem seems to be the one that works the best, as it is a calcium channel blocker. It does not use a lot of the same functionality as a beta blocker would. Beta blockers act on, obviously, betas, and epinephrine and norepinephrine both rely on activation of alphas and betas. Okay, so I can't block them, but what I can do is I can block opposing receptor sites, and hence calcium channel blockade. It's not that you won't get beta blockers, it's just I don't expect beta blockers to work all that well, because they are competing for beta receptors, and I'm already using beta receptors. So it's not like your beta blockers are going to go in there, they're going to displace, epi or norepi, and then fight for it. No, it's just going to go ahead and say, all right, I'm trying, but I'm not working well. So that's where that calcium channel blocker comes into play. But the key there, got to remove that tumor, got to get it out of the body. All right? I'm going to move past all this. Talk about diabetes just briefly. Pretty simple disease to understand. We have type 1 and type 2 diabetes. Okay, let's fast forward. Let's talk about insulin just briefly. Insulin, secreted by the beta Kupffer cells in the pancreas. The beta Kupffer cells produce insulin. Your body perceives an elevation in blood sugar and then dumps insulin into the bloodstream. Goes through the body, goes to the cell, and essentially insulin is the key that unlocks the door of the cell, okay, and allows the blood sugar to come out of the bloodstream and into the cell. That's the goal anyway. So the body heavily relies on insulin, and when we talk about a type 1 diabetic, we're talking about someone who either is born with genetic predisposition, and when the genetic components activate, the pancreas cells either do not produce any insulin whatsoever, or they stop producing insulin at a certain level and they go to almost a nominal level. In other words, you have the capacity to eat, to bring sugar into the bloodstream, but we do not have the capacity to actually secrete insulin and get it into the cell. So, but anyway, that's something you want to think about there. So, when we talk about the fasting regulation of glucose, we're talking about glucagon. Okay, and glucagon is something that we're getting from the liver, not the pancreas. Glucagon and glucose go hand in hand. So what we have is a fasting state that occurs, and when we look at a patient's labs, we're going to be potentially looking at fasting glucose, okay? And also we probably look at A1C. They do tell you something different, though. So when we talk about fasting glucose, we're talking about the body's ability to enter into a state of glycogenolysis and glyconeogenesis and decrease. So we have a decrease in the amount of consumption glucose, and our body perceives that and says to the liver, hey, I need some sugar. Can you give me some? And that's exactly what it does. So epinephrine and glucagon act on the liver, and that results in glycerol, amino acids, and glycogenic chains translating into, and by the way, I'm oversimplifying what is a very, very incredible process. But anyway, essentially that converts into glucose, which we store in our liver. So when epinephrine and glucagon act on the liver, what ends up happening is we take that store of glucose and then we go ahead and dump it into the bloodstream, or we begin to produce more glucose and dump that into the bloodstream. Okay, that's what we're measuring when we are measuring fasting blood sugars. A1C, on the other hand, okay, the A1C levels are a measurement of the amount of blood sugar on average a red blood cell has been exposed to over its lifespan. The average red blood cell lifespan is roughly 90 to 110 days. So, roughly a 3-month window into how high your blood sugars have been on a consistent basis. Type 1 diabetes, destruction of beta Kupffer cells, okay, typically immune regulated, almost always. Idiopathic is incredibly rare. Anyway, I can't make insulin at all, or I make insufficient amount of insulin, okay. I have circulating cortisol and catecholamines that leads to lipolysis. And so we start breaking down fats because my cells are sitting there like, hey, I see the glucose. Where's the insulin? No insulin. Oh, can't use glucose then. So what happens? We get a dump of, not a dump. We can't use insulin, or so we don't have it. We can't use the glucose. So our body's like, what's the next thing we can break down, guys? What do? They start breaking down fat cells or fatty acids so that they can use the sugars in there and start chaining again. What ends up happening is, as we break down these fat cells, we lyse these cells, the lipolysis occurs, and we start dumping ketones as a byproduct of the lysis into the bloodstream. Ketones ultimately result in a decrease in the pH and a state of metabolic acidosis. Diabetic ketoacidosis is entering the conversation now. Extracellular hydrogen ions are exchanged for intracellular potassium, so we have hydrogen in, potassium out, not a good thing. Okay. Oh, that's it? Okay. Anyway, so what ends up happening is we have this massive elevation of sugar in the blood, typically northward of 600. We can't absorb any of it. I have no insulin use or functionality. So we break down fat cells. I increase ketone, both ketonuria and ketone in the bloods. So what happens is I become acidotic, and to compensate, I begin to breathe faster to blow off excess carbon dioxide, because carbon dioxide only exacerbates metabolic acidosis. Okay, so we try and breathe faster, and we end up in a state of breathing called Kussmaul respirations. Kussmaul respirations occur when we breathe faster. They're very shallow, rapid breaths. And that's our body's way of trying to blow off carbon dioxide and partially compensate while we increase our bicarb on the backside. Okay. But what's happening when we go into this state is due to the nature of the hyperglycemia, we could become polydipsic, polyuric, and polyphagic. I'm drinking a lot of water. I'm dehydrated because I'm urinating a ton, and I need to eat a ton because I have no sugar in my body telling me to please eat. At some point, the nausea, vomiting, and the GI symptoms kick in. They don't want to eat at all. They feel terrible. They have no sugar inside the cell, just tons in their bloodstream, and boom, we end up in diabetic ketoacidosis or diabetic coma. DKA is specific to type 1 diabetics. Okay. Type 2 diabetics are a little bit different than type 1s. Okay. And for a lack of a better way to put it, these are diabetics that typically have been considered to earn their diabetes. And what I mean by that is that type 2 diabetes does not occur due to some kind of genetic predisposition. It occurs due to life choice decisions. Okay, so lack of exercise or sedentary lifestyle, poor dietary choices, poor liquid consumption, sodas especially, and high sugar juices, persistent elevation of A1C, persistent elevation of blood sugar, and overactivation of beta Kupffer cells ultimately leads to a state of resistance within the body. So what's happening is this. The cell has that lock on the outside. Insulin is the key. In a state where you're type 2 diabetic, what's happened is you're dumping, because your blood sugar is elevated at all times. Okay? And you're uncontrollably dumping insulin into the bloodstream. Okay, well, partay. We're going to go unlock the door, let the blood sugar in. That's how it should work. But your cells have gotten tired of the shenanigans of excess insulin and say, you know what, we're going to change the locks. And so that's what they do. The cells actually go out. They go to the cell Home Depot, buy a new lock set, come back to the cell and change the lock on the cell. Insulin comes out of the pancreas into the bloodstream, from the bloodstream to the cell. And the cell says, all right, go ahead. And insulin tries to unlock the cell, but it cannot unlock the cell. It cannot open the door of the cell and let that sugar in because it is no longer the key that fits that lock. We call that insulin resistance. Insulin resistance occurs because of overexposure of insulin to cells. They adapt, they get tired of shenanigans, and they change. That insulin no longer works on that cell, and therefore the blood sugar never leaves the bloodstream and enters the cell, resulting in elevated blood sugar levels. Okay? What do we have to do? We either give oral anti-diabetic medications or we start giving insulin. And if we're doing exogenous insulin injections, which is very common, we're either doing porcine or synthesized insulin. So, fun facts. However, I'm going to point out, once again, type 1 diabetics get DKA. Type 2 diabetics, and I misspoke earlier, my apologies, glucose greater than 300 on DKA. I sincerely apologize. I think I said 600. 600 is consistent with HHNS, okay? And for those of you who don't remember what HHNS is, it's hyperglycemic hyperosmolar non-ketotic syndrome, okay? So that's HHNS, greater than 600, no ketone breakdown at all, okay? pH, normal. Sodium, potassium, can be all the above. Hematocrit, hemoglobin, and protein, high. Everything else, potentially high. The key is no ketones. The minute you have any ketones, period, whether it's type 1, type 2, you are in DKA, diabetic ketoacidosis. Okay, so please keep that in mind. How do we treat it? We can use sulfonylureas, bugonides, alpha-glucosidase inhibitors, and thiazolidinediones. Let's try that again. Thiazolidinediones. I probably still said it wrong. Either way, essentially what we're doing is trying to do one of a couple things. Okay, I'm trying to increase insulin production, okay, and insulin release with sulfonylureas. I'm trying to suppress glyconeogenesis with bugonides, okay, and enhance glucose uptake by the tissues and by the cells. With alpha-glucosidase inhibitors, we're diminishing hyperglycemia by delaying carbohydrate absorption in the GI tract. Thiazolidinediones, I still said it wrong, increase tissue sensitivity to insulin. In other words, make it to where the cells change the locks back to the original lock so that your insulin works better on those cells once again. Okay, these don't always work. The direct treatment, though, in the short term and management of DKA or HHNS is going to be a insulin drip or subcutaneous injections of insulin or exogenous insulin. Okay, type 1 diabetics are insulin dependent. Type 2s, roughly 40 to 50% of those that are type 2s, these are old numbers actually, 40 to 50% of type 2 diabetics become insulin dependent and require injections several times a day in order to typically 4 times a day, to manage their diabetes. Okay, you got to know your types of insulin. Let's go back to Professor Scheid's class, semester number 2. Let's go ahead and look at rapid acting, short acting, intermediate acting, and long acting. No, I'm not going over the half-life. No, I'm not going over onset. No, I'm not going after duration. These are things you should already know. Okay, and for those of you that can't remember, here's a helpful list. Some of the newer agents that we see, GLP-1 and GIP inhibitors, okay, also known as incretins or incretins. We actually are blocking enzymatic breakdown of incretin hormones, GLP and GIP, or GLP, excuse me. Inhibits release of glucagon, increases insulin release from beta Kupffer cells. It is only an injectable. These are not orals, and you cannot use incretins with insulin. We have amylins, okay? These are used in conjunction with insulin, but they are injected separately, and they manage hyperglycemic states. We have SGL2 inhibitors. These prevent reabsorption of glucose in the kidneys, and we actually end up increasing glucose output in the urine. So we've already talked about these and even tested on these, so I'm not going to go over these again. I'm just going to remind you what they are. DI, not enough antidiuretic hormone, just dumping fluids. SIADH, too much ADH, retaining fluid. Okay, so keep that in mind. Thank you for listening to this lecture, and I will talk to you all again soon.